Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, I'd like to talk about typical and atypical locations of carpal and tarsal collisions and with diagnostic pitfalls. Teaching points includes to know the typical locations of carpal and tarsal tunnels and to see the atypical locations of carpal and tarsal collisions, and finally to understand the pitfalls and advantages of radiography, CT, and MRI. There are two primary forms of collision. The first one is osseous collision. The next one is non-osseous collision. Non-osseous collision includes cartilaginous, fibrous, or both. A carpal collision is most commonly occurred in lunotriquetral. Then next one is the capitohemate and pisohemate. Afro-Caribbean populations have more carpal collisions other than Hispanic and Caucasian. Isolated fusion occurs within the same row. When the carpal collision involves both proximal and distal carpal rows, they can be related to syndrome. Mostly asymptomatic, but it can cause early degenerative changes in the adjacent joints. Common location for tarsal collision is calcaneal-navicular and talocalcaneal. In contrast to carpal collisions, tarsal collisions can cause pain, stiffness, and pes planus. Radiography can show bone bar close proximity of bones and irregular surface of bones. The CT can show more precise evaluation of the extent of collision, particularly at the subtalar joint. Can readily depict associated degenerative changes. MRI can show more bone marrow contiguity across the fused joint. In cartilaginous collision, the signal intensity can be similar to that of fluid or cartilage in the joint space. In fibrous collision, we can see intermediate to low signal intensity. Typical locations of carpal collisions are lunotriquetral and capitohemate. Let's start with this case. 28-year-old female with rheumatoid arthritis shows osseous collisions between lunate and triquetrum bilaterally. You can see on the radiograph and also on the right side, MRI shows continuous bone bar between two bones. 35-year-old female with thumb carpometacarpal arthroplasty shows osseous collision between capitate and hemate. Atypical locations of carpal collision includes pisohemate and scaphotrapezial collision. 24-year-old female with systemic lupus erythematosus shows osseous collisions between pisiform and hemate bilaterally. 36-year-old male with Larsen syndrome shows osseous scaphotrapezial collision and lunotriquetral collision in the same wrist. Let's move to tarsal collisions. Typical locations are talocalcaneal and calcaneal-navicular. 31-year-old female with foot pain shows non-osseous collision between talus and calcaneus, and we can see C sign. 49-year-old male with lupus shows osseous coalition between anterior calcaneal process and navicular, and we can see the elongated anterior calcaneal process, which can be called anterior nose side as well. Atypical locations of tarsal coalitions are talo-navicular, cubonavicular, the first navicular cuneiform, and lateral cuneiform, the third metatarsal coalition. 43-year-old male with polyarthralgia shows osseous coalition between talus and navicular. And on the frontal view of ankle shows ball and socket appearance of ankle joint. 45-year-old female with pain shows non-osseous coalition between cuboid and navicular. On T2 axial, MRI shows high signal intensity, suggesting cartilaginous coalition. 59-year-old male with pes planus shows osseous and non-osseous coalitions on the left and right side between navicular and medial cuneiform. 39-year-old male shows non-osseous coalition between lateral cuneiform and the third metatarsal base, both on radiography and CT. We reviewed typical location and atypical locations of carpal and tarsal coalitions and pitfalls and advantages of radiography, CT, and MRI. Thank you very much.